Everyone, and welcome back to yet another remote cardiovascular medicine grand rounds. Today, I have the pleasure of introducing Dr. Tariq Ahmad. Dr. Ahmad received his bachelor's degree from NYU in mathematics and biology, subsequently obtained his MD degree from SUNY Stony Brook. From there, he moved to Boston for his clinical training. He was an intern and resident at Brigham and Women's Hospital. While up in Boston, he did a research fellowship and pursued an MPH degree from the Harvard School of Public Health. Subsequently, Dr. Ahmad moved down to Durham, North Carolina, where he completed fellowships in general cardiology, cardiovascular research at the Duke Clinical Research Institute, and then finally an advanced heart failure transplant fellowship at Duke as well. From there, Dr. Ahmad moved to New Haven, where he has been since. Dr. Ahmad is currently assistant professor of medicine and the medical director of advanced heart failure. Dr. Ahmad has been extraordinarily productive with research and has been particularly involved in the running of pragmatic clinical trials across our health system. Has been trying to understand how to best utilize real-world data to answer key clinical questions in heart failure. And beyond that, Dr. Ahmad has also been an exemplary mentor and has gone to great lengths to help to shape the futures of several medical students, residents, and fellows as they head towards careers in academic medicine. He's done a real terrific job at integrating folks all along the training spectrum into cardiovascular research. So it is a great pleasure to be introducing Dr. Ahmad. Thank you very much.
And thank you for that incredibly kind introduction. Thanks to you and Oyeri for organizing this. You've done an incredible job of it, and thank you especially to Kristen Piscatelli and Elizabeth Whiteman for basically setting all these grand rounds up. So really thank you to the entire team for this. Hope everyone had an excellent long weekend, and really thank you for this honor of allowing me to present. I think I just hit 5 years at Yale, so it's great honor to be able to talk to my friends and colleagues. So what I'll talk today about is improving care of heart failure patients at Yale and beyond. These are my disclosures. So as many times in grand rounds, we're going to start with a clinical case, and I'll be getting back to this case several times, and I'm hoping to use this case to make the points that I'll make during my talk. This is not an unusual story. We see this all the time in the heart failure group. So Ms. Smith is a 65-year-old female with a history of non-ischemic dilated cardiomyopathy. Her ejection fraction is 25%, was first diagnosed 15 years back. She has a defibrillator that was placed in 2015. Over the last 5 years, she has been hospitalized twice for trouble breathing. The cardiologist notes mentions her being stable with NYHA class 2 symptoms. Her blood pressures during that time are low normal in clinic. Her labs are significant for a creatinine of 1.5 and an NT-proBNP of 4,500. Her medications include carvedilol 6.25 twice a day, lisinopril, bumetanide, digoxin, and atorvastatin. She is admitted to our CCU here at Yale after presenting to an outside hospital with dyspnea, and she was noted to be very hypotensive. Her creatinine is now 2.8. She started on dopamine, and a balloon pump is placed after right heart cath shows right atrial pressure of 15 and a wedge pressure of 45 with an index of 1.4. An advanced heart failure consult is requested. So just keep this case in mind as we go through the different challenges that I feel exist in heart failure. I think these are the three biggest challenges in my mind. It's risk prediction, guideline-directed medical therapy, GDMT, and then use of advanced therapies. So let's talk a little bit about risk prediction in heart failure. This is something that might be familiar to many of us. We should think about this every time we order any tests in clinical medicine. We have to get a sense of whether these tests are precise or accurate. It's not the same thing. I would argue that when you go back to the case, the way that the risk for the patient was described using ejection fraction and NYHA class is both imprecise and inaccurate. And this has been known for quite some time, including some work that we did. So this is a paper that we did looking at the NYHA class across different randomized controlled trials. And what we found was that NYHA class 2, for example, in one study can imply a much higher risk than NYHA class 3 in a different study. It does not correlate with objective assessments of patient outcomes, including KCCQ, which is supposed to get a sense of how a person is feeling with heart failure. The ejection fraction is similarly an incredibly poor predictor of outcomes. You will know in the CCU or on the floors when a patient is being presented, there is a key focus on ejection fraction. And if you say someone's ejection fraction is 20, everyone stands back and assumes that the patient is very, very sick. But this is a study that we did from the SWEET-HF registry of heart failure patients. It's one of the best phenotype heart failure registries around. And as you could see, what we found was ejection fraction doesn't really allow you to tell much in terms of the absolute risk of the patient. In fact, a more data-driven approach does a much, much better job in terms of being able to assess outcomes from heart failure. And again, this is not something that is that we found. Several other studies have found that it's something that is well known within the heart failure community. And then finally, this is another study that we did where we looked to see if the commonly cited bedside assessments of heart failure, the cold, wet, warm, dry classification system that Lynn Stevenson borrowed from Forrester Diamond when they did their initial studies of cardiac catheterization, right heart catheterizations in people with acute myocardial infarction, and has really taken off in terms of use in clinical settings. We found in the ESCAPE database that it does not correlate with adverse outcomes, whereas use of objective variables does. And those clusters based on those variables did predict outcomes, even though this was a small study. And the hemodynamic profiles had no correlation with those patient variable-based clusters. So hopefully I've had you think a little bit about our current state of risk prediction in heart failure not being great. The bigger question is, well, does it matter? Our assumption has been that if you predict outcomes better, and there's thousands of papers out there that say that their risk predictor, improves the C statistic from 0.85 to 0.9, the assumption is that better risk prediction will lead to better clinical decision making. Surprisingly, no one has ever tested that. We don't know for sure whether improving prediction does in fact lead to better patient outcomes, which is why we designed and are running the REVEAL-HF study, the risk evaluation and its impact on clinical decision-making and outcomes in heart failure. This is a pragmatic randomized controlled trial using just the EHR. that informs practitioners about their heart failure patients' 1-year predicted mortality using validated data. So it calculates data from the EHR using objective variables. The risk prediction abilities of the algorithm are better than published data with a C-statistic of around 0.8. And we're examining the impact of this information on rates of post-discharge hospitalization, mortality, length of stay, use of medications, referral to EP, palliative care, and then use of therapies such as heart transplantation or mechanical circulatory support. This is the overall design of the study. The patients are randomized at time of hospitalization if they meet the criteria, which is age greater than 18 and NT-proBNP of more than 500 and IV diuretics within the first 24 hours. And the providers are randomized to half the providers will get information on the risk score and half would not. This is what the alert looks like. I know some of you might have seen this on the floors. And then this is a really interesting kind of additional thing that Perry Wilson wanted to add, which I thought was a great idea, where you ask the provider whether they think the risk assessment seems appropriate, too high, too low, or they're not sure, to kind of engage the provider and get a sense of how their perception of risk differs from the algorithm. This is where we are as of last month. We've crossed 2,000 patients randomized for a goal of 3,200. So very close in terms of randomization scheme. This is one interesting thing from finding from preliminary findings, where we found that for a large percentage of the patients, the providers felt that the risk for across the spectrum was too low. So they felt that the risk assessment was too low compared to what they in their mind think the risk is for the patient. So this will be interesting to delve deeper into once we get the results. So moving on to guideline-directed medical therapy, and this is something that is used quite a bit within the heart failure space. So those who are unfamiliar with the phrase, I apologize, but what guideline-directed medical therapy implies is that there's a certain group of medication that have been used, that have been shown to improve outcomes in patients with primarily heart failure with reduced ejection fraction. And there's a lot of efforts around implementation science to get patients on the right medications. I'm not going to discuss heart failure with preserved ejection fraction because we do not, other than for a subset of patients, such as those with amyloid or with hypertrophic cardiomyopathy, that Dan Jacoby has done such an incredible job of building a global kind of presence here at Yale. For those patients, for the most part, those patients do not have any pharmacotherapies that have been shown to reduce outcomes. So I'll focus on heart failure with reduced ejection fraction. This is a nice paper that came out in Lancet recently by my colleagues up in Boston. And what they showed was that there's 3 classes of drugs that have been shown to reduce mortality in patients with heart failure and reduce ejection fraction. And these are MRAs, ARNIs. So ARNI is angiotensin receptor neprilysin inhibitor, Entresto, and SGLT2 inhibitors. And just as a tangential comment, the SGLT2 inhibitors were tested as anti-diabetic medications, but we have one of the world experts on the topic here at Yale, Silvio Nzuki. But within the cardiology community, it's now accepted that SGLT2 inhibitors are heart failure medications and not anti-diabetic. So their use in heart failure does not depend on whether or not the patient has diabetes or not. So what they found was that with comprehensive disease-modifying therapy, you can get a additional almost 3 years for an 80-year-old and more than 8 years for a 55-year-old patient. So you can get dramatic improvements in actual hard outcomes if you use these therapies in these patients. And just to put this into perspective, we really don't have therapies for most chronic diseases that deliver such impressive reductions in outcomes. This is an editorial that we recently wrote, and we made the point that despite the fact that we have these therapies that improve outcomes dramatically, their use is dismal. So not only are the recommendations that patients should be on these therapies, but they should be on appropriate doses of those therapies. So that's a key component to getting benefit from the therapy. So they also need to be on appropriate doses. And what Nihar and I made the point was that in national registries, they find that less than 1% of patients who are eligible are receiving appropriate medications of the right dose. And as reimbursement for heart failure becomes more and more focused on quality rather than quantity of care, healthcare systems are going to be more and more responsible for what we do with the patient population we're taking care of. So there really there is a strong need to try to get these patients on these therapies. For that, we created, with our help from our JDAD colleagues, and this has been one of the most fun experiences I've had at Yale, was to create a live heart failure dashboard of patients across the system. So this is just one, if you will, one page of the dashboard, and it gives you a lot of information on the heart failure patients within the Yale New Haven system. Now, heart failure, as many of you taking care of patients with heart failure, is a syndrome, and there's no clear blood test or diagnostic criteria that makes someone have heart failure versus not. This is, but in this case, we have about 18,000 patients with an echo that allows us to get closer to being able to appropriately phenotype these patients. But in general, this gives you a sense of what medications these patients are. In the subset of patients who have an ejection fraction less than 40, so they presumably have heart failure with reduced ejection fraction. You can see the number of medication, the percentage of them on specific medication. So beta blocker, for example, is around 75%. You have 10% of people on calcium channel blockers, very few people on SGLT2 inhibitors, and Entresto usage is still south of 30%. So you get a snapshot on how we are doing with heart failure therapeutics across the heart failure system. This has really allowed us to have a live look at heart failure across the system. So this, for example, on the left, and this goes beyond just GDMT. So this is again a potential use of the dashboard. Was that when COVID happened, we quickly asked whether how many people are getting tested, how many are being positive. This is a query that I did yesterday, and it kind of shows you where the patients are who tested negative for COVID within the heart failure registry. So more than 6,000 people tested negative across the state, and then who tested positive. So that's about 462 patients, and they cluster around New Haven and Bridgeport, and then some around Westchester and the Greenwich area. So it's very interesting to kind of see where those patients are clustering around, so we can make specific kind of system level decisions about these patients. And that's something that we we placed on the preprint server, and it's in press at PLOS right now. So getting back to this question of HFrEF across the Yale New Haven health system, this shows all the patients with heart failure with reduced ejection fraction in the state. There's more than 4,000 patients. If you go, you can click on these individual areas, it'll give you detailed information on all these patients. So yesterday, I pulled up all the patients with HFrEF, the 4,345 who are on quadruple therapy as we had defined it. And this is just being on the therapy. It doesn't take into account whether they're on the right doses of the therapies. And that was 82 patients. So 82 patients out of 45 were on quadruple therapy. So one might say, well, quadruple therapy is a relatively new concept. Maybe implementation of these findings in general can take several years. Well, what about triple therapy that's been in the guidelines for many years? And when you looked at triple therapy, again, this is people who are on triple therapy defined as beta blocker, ARNI, and spironolactone or a different MRA, and not taking dose into account. Only 509 patients, which is about 11% of the entire group of patients, were on triple therapy, which again is far lower than we would like to be. And if you ask us whether our registry is how does it compare to national data, the CHAMP-HF registry out of Duke was funded by Novartis and probably cost millions of dollars to set up. And if you look at our registry, which has more patients in it, and it's a live registry, the demographics are almost identical. So, we have more people on ARNI and more people on SGLT2 inhibitor because we're able to get a live snapshot, whereas CHAMP has to go back to the individual sites and get all the data all over again. So. But in terms of demographics, our data is very, very similar, giving us, and I know Alan Shaw shows this slide that Yale New Haven Health System is an incredible representation of heart failure or any other disease state across the country, because we represent demographics that are seen in the entire country. With that, we're about to launch our PROMPT-HF study, which is a pragmatic trial of messaging to providers about treatment in heart failure. We'll give them information on the provider's information to the patient, and then an order set, and we will see if that improves use of GDMT across the system or not. Finally, I'll talk about something that is near and dear to me. This is advanced therapies at Yale New Haven Hospital. Now, this is something that I talk to with the trainees quite a bit. So stage D heart failure, which is heart failure that has become refractory to conventional medical therapy, implying that the patients can't tolerate guideline-directed medical therapy. They get and you must remember that most of GDMT are antihypertensives. So when you have advanced heart failure, you can get hypotensive. You're not able to tolerate these therapies, and you start showing signs of end organ dysfunction. So if you go back to our initial patient, the fact that her creatinine was going up and her NT-proBNP levels, which it's important to realize are not actually a measure of volume status. There is a measure of neurohormonal dysregulation. So her NT-proBNP levels were incredibly high as well. So those two variables on their own suggest that her risk is incredibly high. So with stage D heart failure patients, you have, when you're told that you have stage D heart failure, you have a survival rate at 1 year that is about 20%. So, and the only two therapies that have been shown to extend life in that case are heart transplant or LVAD. And this is something that is incredibly important to understand because we tend to not realize the prognosis from heart failure in terms of overall risk. So this is something that I think about when I'm thinking about patients getting referred for advanced therapies. And it's very similar to climbing a very difficult mountain. I think of K2 as an example of a very difficult mountain to climb. So this is kind of when we get referral for advanced therapies, but that is not the beginning, because just the referral itself starts a long process. There is an extensive medical, social, psychiatric, surgical evaluation that happens. This can take quite a lot of time to do, and some patients may be beyond being able to reverse the extent of their disease to be able to be candidates for these advanced therapies. Then there's very extensive post-operative management that requires incredible amounts of skill, because how the patients do right after their surgery defines kind of how their long-term prognosis is going to be. So when we triggered the referral for advanced therapies, there's a long path to being able to get the person the advanced therapies. So that's something to keep in mind, because that process can take a long time. And in the case of heart transplantation, even when you're listed, it can take months to get a heart, because they're not the predictability of being able to get an organ is just not there. A lot of people ask me, well, why can't we just put someone on inotropes? Start them on inotropes. Their hemodynamics look great, and then we will send them home. And since their hemodynamics were much better than they came up in with, they will do fine. And that is one of the most inaccurate assumptions that we have. There have been numerous studies that have shown that even if you normalize hemodynamics as much as you can, medications inotrope medications will increase mortality. So we've kind of seen this time and time again in cardiology, where therapies that improve intermediate phenotypes do not necessarily improve long-term outcomes. We see this with antiarrhythmics for treatment of PVCs and HDL, but it's profoundly the case in terms of inotropes, where all the randomized controlled trials done of inotropes either killed patients or caused increased risk of adverse events, to the point that no inotrope is FDA approved for chronic usage. And that's kind of an important thing to keep in mind when we're taking care of these advanced heart failure patients. This is our paper where we reviewed every single randomized controlled trial of inotropes, and we make the point that these inotropes, most of which act by increasing intracellular calcium, were stopped early or stopped because they caused increased risk of death in the active arm. So shifting gears to left ventricular assist devices, we started a small group of medical students, residents, and fellows last year, and that's Nihar and myself, with the goal of trying to do some, advance the field in terms of heart failure and advanced therapies. And this is some of the work that we did in LVADs, and it's in just a period of the year, it's been within the heart failure community considered some of the most important work that's been done in the field of advanced heart failure. These papers asked very important questions in terms of who is a candidate for LVAD and how do patients do who may not meet, who may have certain risk factors going into LVAD. So, for example, psychiatric comorbidities can play a big role in candidacy for LVADs, where people are turned down for this therapy. And we did an analysis that was led by a CT surgery resident that was incredibly well received in the literature. He also looked at whether tricuspid valve should be repaired during LVAD implantation. It's an important point because a lot of these patients have tricuspid regurg, and he found that it was associated with worse outcomes, and that is likely going to end up in the upcoming guidelines. And other manuscripts, such as use of neurohormonal blockade after LVAD patients, got a lot of attention from the heart failure community. It was led by one of our residents who's now going over to MGH for cardiology, as well as other key studies. So this has been actually a great experience working with residents and fellows and med students. And these are just a small example of the number of papers we've been able to write that are clinically very important. So, and some of you might not know this, but there was a allocation change in how in heart transplantation. One of the things that made it difficult to do heart transplants, particularly in the Northeast, was the way the allocation rules were set up. The new allocation system came into was put into place in October of 2018, and there's several changes that were made that were going to allow sicker patients to get higher status, urgency status for heart transplantation. And this is a paper that we submitted over the weekend to circulation that was also led by one of the CT surgery residents. And what he found, looking at the UNOS database, was that with the new allocation system, there was a dramatic decrease in the use of LVADs. So patients who were sick and need transplantation were getting a heart transplant instead of having to get an LVAD en route to getting a transplant, as many of us have seen both here at Yale and nationally, that the old allocation system rewarded centers for putting LVADs in before a patient would get a heart transplant. But after the allocation change, you see the percentage of people getting a heart transplant from an LVAD went from close to 50% in April of 2017 to close to 10% in April of 2020. So this has been a dramatic decrease in the use of LVADs as a bridge to therapy. And we think that that entire kind of field of using LVADs as a bridge to therapy might come to essentially close to zero. So this, I felt, was a very, very important finding, and it's really interesting that we were able to do this analysis and get out, and it's it generated a lot of excitement. We shared this with a number of people who are experts in transplantation, and they really impressed with our analyses. Heart transplantation at Yale has come a long way over the last few years. So this is incredible work by Harlan and Makoto, where they looked at our heart transplantation data, and compared to other centers in our UNOS region, you could see that, I mean, for many, many years before, Yale was not doing many transplants. I mean, it was doing the bare minimum required to keep to have a heart transplant program, but especially with the new allocation system and a change in our philosophy, we were able to increase heart transplantation dramatically. And last year, we were the #1 center in the Northeast for heart transplants. And what Makoto and Harlan found was that the outcomes with this strategy were just as good as before. We got our data from SRTR recently and showed that our outcomes are actually much better than national. And the other thing was that our volumes are quite a lot better than they used to be. So even if our outcomes were okay before, we used to sit back here in terms of volume, but our program volume went up as well. So we were able to offer patients the gold standard therapy with outcomes that are better than most other programs with that volume. So that's been a really incredibly exciting team effort that I've been lucky enough to be a part of. Finally, we're coming to an end, but there are a few things that we've done in the last few months to increase the donor pool. This on the left is the head of transplantation, the Transplant Institute at NYU, who needed a heart transplant. And he accepted a heart that was from a patient who had active hepatitis C. Now, with the new medications that we have, we can cure hepatitis C to the point that taking hearts from patients who have active hep C, which is a significant percentage of the donor pool, has become the standard of care. And about a month and a half back, we were able to start the process of doing that at Yale. And we did the first hep C positive, nucleic acid positive, mean that they can detect hep C in the donor, solid organ transplant at Yale, and the patient's doing well. So that was an incredible team effort. We had to get input from an entire group of ID and pharmacists, and it went really well. So that was a great thing that we were able to do for patients. And now most of our patients have consented for hep C organs, so we'll be able to offer them hep C organs that with a cure rate of more than 99% when if they do end up getting an organ. And second, this is a post from Arnar Gerson, who is our chief of cardiac surgery and has played a key role in the heart transplantation program. It's been just incredible working with him and the rest of the team. And Chris Malayan, who is one of our young heart failure faculty, led this, where we are now able to do DCD hearts using a TransMedics device. We did our first one about 2 weeks back, went incredibly well. And this in some ways will be the future of heart transplantation, where we'll be able to offer hearts to patients who from regions far further from the Northeast with much better outcomes. So this is going to be a game changer in heart transplantation, and we're one of the handful of centers that offer this. So we're super excited about this, and we've already done one with many hopefully lined up for the next month. So in summary, if you referrals for advanced heart failure team, if you to make it as simple as possible, like I think if you have a patient who has an ejection fraction less than 35%, has had a hospitalization, defibrillator shock, are not tolerating GDMT and needed inotropes, it would be very helpful to get plugged in with the patient to kind of follow them along in case they do need advanced therapies. So getting back to a patient, I think that some of the things that we talked about would be relevant in this case. So this patient is 65 years old. Obviously, the ejection fraction of 25% and the NYHA class 2 does not completely capture how what the patient's risk is. I think the fact that the blood pressures are on the lower side, the creatinine is elevated, the NT-proBNP is actually quite high, makes her, in my mind, quite a high-risk patient. The second point would be that this patient is not on GDMT, so carvedilol 6.25 is good to start off with, but we should try to increase that to as high as we can get compared to what was used in the clinical trials. Lisinopril is it's probably if the patient is okay with and doesn't have any clear contraindications to it, should be replaced by an ARNI based on the guidelines. We should, in this case, be using an MRA, so either plerone or spironolactone, most likely spironolactone to start off with, and an SGLT2 inhibitor. The data for SGLT2 inhibitors are for dapagliflozin and empagliflozin. So those are the two ones that have been shown recently in clinical trials to improve outcomes. The data for digoxin is not clear. So especially in someone with the creatinine going up, it's yet unclear as to what role digoxin has in heart failure. And then statins are see a lot of patients with heart failure on them. Like based on the clinical trials, at least, the statins do not improve outcomes, even in ischemic cardiomyopathy when you have advanced heart failure. She's admitted to the CCU after presenting to an outside hospital with hypotension. So getting back to those medications, there is a real possibility that if she was on appropriate GDMT, that she could have remained stable for much longer. Now she is in the CCU with a creatinine of 2.8, so she obviously has, AKI. She started on a dopamine and a balloon pump is placed, and then hemodynamics are very abnormal. Something to keep in mind is that when this happens, even we're a 65-year-old patient, if there's no clear contraindications, the gold standard would be heart transplantation, but there's several things that can make a heart transplantation be a high-risk procedure in this case. Now, the creatinine is elevated, so if she ends up on dialysis after the surgery, that would lead to worse outcomes. The wedge pressure is 45. The PA pressure, if it's fixed and elevated, would also lead to RV failure after the transplant. And then depending on what her blood type is, how big she is, it might take months for us to get a suitable organ. So this might be something that would have been beneficial to do sooner rather than later, now that she's in the ICU, incredibly ill. So that's just something to keep in mind as we look at these patients, because they look fine until something tips them over. So finally, I just wanted to end with this. This is our recent heart transplant patient who got a heart transplant off an LVAD. He was listed at all the centers in Boston for several years, and he heard that Yale was doing quite a lot of transplants. He came down here. We transplanted him, and he's just completed a 100-mile bike ride across Maine, socially distant bike ride, and he's doing incredibly well. And it's for all the things that I'm biased, obviously, but in medicine, there is very little that is as dramatic as heart transplantation in terms of improving a patient's quality of life and outcomes. So with that, thank you very much. Really an honor to be able to speak with everyone about this, and I'll take questions now.
Tariq, that was an absolutely terrific talk. Thank you very much. For folks who are interested in asking questions, you can either type them into the chat function or use the raise hand function, so we can ask things in a orderly fashion. Maybe I'll start things off. So Tariq, you talked about how our use of GDMT is not optimal at this point. How is our use of defibrillators and CRT in these HFrEF patients?
Dan, that's an excellent question. So we do have that data on the dashboard, and there is, I don't know the exact numbers, but there's a significant number of patients with an ejection fraction less than 30 who do not have defibrillators. Now, obviously, not everyone qualifies for a defibrillator. These patients, some of them may be very old or have other comorbid conditions, but at the very least, it would be something that's discussed with them. So I think that using the data to kind of come up with a strategy to make sure that at least it's been discussed with them would be great. I know that you and other people in the EP team are working to put QRS complex into these into the dashboard as well. I think that would help us incredibly in terms of finding out how many of these patients are on CRT or not. I know Jim Freeman may also already have created a dashboard for AFib as well. So we're moving towards using more and more data to be able to manage these patients.
Thank you. There's a question entered in the chat function asking what's the status of LVAD as a destination therapy?
So Dr. Salsa, that's a really good question. I think that, we're pushing the boundary in terms of heart transplants. So if you use Dick Cheney as an example, like Dick Cheney had an LVAD when he was 69 and had a heart transplant at 71, and now he's doing quite well. And we've had really good outcomes with extended criteria heart transplants in patients all the way up to 75. So, you'll take a heart that normally you would not be using for a younger patient. You match the donor to the recipient, which one of the philosophical changes we made. The hearts are perfectly good, but we've had good outcomes with this approach. So if you go all the way up to 75 for a heart transplant, the window for someone who should get a DT LVAD is closing quite a bit. So there's very few people who kind of meet candidacy for LVAD at that point. Because once you get more than 80, we see that the outcomes are terrible. So it's kind of the 75 to 80 years of age, and whether patients are willing to deal with all the downsides to having an LVAD. Now, a result of the allocation system, LVAD numbers have gone down dramatically. So if you were to look at the Northeast, for example, Tufts used to do 60 LVADs a year, and this year they've done 3. And volumes of LVADs across the country are going down dramatically as a result. Dr. Price asked a question of the added cost of ARNI and SGLT2 inhibitors. I mean, that's a really important question. I know Nihar is one of the experts on kind of value, and he's working with these companies quite a lot in this regard. So I think that that's something that that we think about quite a lot in the inpatient setting. The pharmacists do a analysis of best possible GDMT for what costs the patients can afford. I know that for a lot of the patients, these medications they're covered quite well. But in the percentage of patients who are not, that really can be a big challenge. And I don't know, Nihar, if you have any thoughts on, because you know a lot more about kind of cost and effectiveness. But the other one thing I would say is that sometimes if you think that if someone's getting discharged with heart failure, and you know that their risk of readmission is going to go down dramatically, as Eric showed in his trial with these medications, then the healthcare system might end up, benefiting quite a lot if these patients are starting on these therapies, and then there may be new ways to kind of come up with how to pay for these therapies to reduce these adverse outcomes.
Tariq, hey, it's Nihar. Sorry, I don't want to get too into this. I know there's many other good questions that are coming in for you about terrific presentation. Dan, I think it's a very good point. It's a very good question. I think we always have to think about that from the standpoint of the patient, what they're going to face in terms of cost sharing, or when they go to CVS or Walgreens to pick up their medicine, what they're going to be confronting. That said, it sort of highlights one of the true vagaries of our, of our system, that, a drug that might cost, a little bit more relative to another, but can reduce the risk of rehospitalization by 20, 30, 35%, when that hospitalization is costing $20,000, $25,000, $30,000. And yet we're so obsessed with, is the cost of the drug, 200 or 300 or 400. I mean, that's important. That's real dollars for real people. And especially when, many people are struggling. But that said, I think it really highlights, some of the misaligned incentives in our healthcare system. And certainly I think the push towards value-based models of care, where the system is actually, has a financial stake in trying to deliver best quality, best value care. And that might mean actually prescribing more of a slightly more expensive medication if you think it's better for the patient, you think it can reduce overall utilization and overall cost. That's certainly a win-win-win. And I think what we should all be aiming for. We're certainly not there yet. And so cost is very much, front of mind for many people, and most importantly for our patients. But I do think it's important to have kind of a wider lens on it. And I think going forward, that's going to become really, even more important. Sorry, Tariq, I don't want to.
No, thanks, Nihar. That was perfect. So Dan asked a really, really important question that we talk about all the time within our group. How do you know if someone is stage D heart failure? Most of the referrals we get, we feel that, we never think that someone's referred too early. So I think one of the things that the kind of 5 things that I talked about are something that I feel should trigger an advanced heart failure referral. So if someone has had a defibrillator shock, if someone's hospitalized with HFrEF, if someone is not able to tolerate GDMT, so you go up to the beta blocker from 6.25 to 12.5, and then they start to get hypotensive and not doing well. Or if someone is hospitalized and needed inotropes, I think those are all things that should trigger an advanced heart failure referral. And then, we're always happy to see, to kind of feel that, we could get people through with medical therapy. We're not, even if we can find, like 5% of the patients sent to us may need advanced therapies, I think that's a good sensitivity and specificity in my mind.
Thanks. And Jeff Bender has a question. Jeff, if you can unmute yourself and ask.
Sure. Here we go. So Tariq, terrific talk, and more importantly, the reason I wanted to say something rather than just type is that I wanted to congratulate you on your fantastic work. I do not think it's overstated how important this work has been in the heart failure community. Very impactful, amongst the most important work, as you said. So you had a nice cartoon. Maybe I pay the most attention to the cartoons, but you had a nice cartoon which said fortunes $25 and genomics or gene sequencing $2,500 in the context of your risk prediction. I wondered if you could just comment. I know we're not there yet, but what's the current state of the art, or where are we in data generation looking at genetic profiles that may help predict risk?
Yeah, Jeff, I mean, that's an incredibly important question. So I think that most people will admit to the fact that the phenotyping of heart failure currently is terrible. So what we call heart failure is a group of multiple different disease states that have been clumped together. That's some of the work we've done that I haven't showed, but I think that's where kind of getting a better understanding of the biology of the disease comes into place. Because if you're starting to treat, we've gone quite a long way in precision medicine in cancers, for example, where you're not going to be treating patients for abdominal cancer, for example. You would treat them for the specific mutations that they have. Unfortunately, we're not there in heart failure, where we have this fake dichotomy based on ejection fraction that we treat for. And I still think that we have a long way to go in terms of being able to understand the biology of the disease and then tailor therapies accordingly. I mean, Dan's work in HCM is a really good example of that, where it's targeted to a specific disease state. But for now, I think that we can come up with numerous ways to risk predict heart failure. But until we tie that together with interventions, it's unclear as to what the benefit is of doing very kind of fancy analytics to be able to predict outcomes where we don't really know whether using those outcomes, how should we use that prediction methodology to make clinical decisions that improve patient care.
Thank you.
If there's no other questions, maybe I can ask maybe a question. Tariq, well done. Nothing less expected. Really a great talk. I also want to congratulate the team, the heart failure team, and you in your role for leveraging multiple different sources of data to really expand opportunities to advance our knowledge, not only using available BioLink data sets like Intermax, which you've done so well, but also to constructing and leveraging our EHS to inform not only how we should give care nationally, but also how we should take care of our own patients. My question to you is related to, as you think now into the future, I mean, I guess one comment would be, I don't know what the right ratio of referral to evaluation should be, but it probably needs to be, for every 100 to maybe 1,000 patients referred, we end up listing 1 or 2 patients. We really have to open the funnel a fair bit and widen the top part of that funnel because it is so important and really an ethical, I would say, imperative for our system and our organization to be able to provide that kind of care for the community of Connecticut. What do you think are kind of when you look at the landscape now with LVAD numbers decreasing and our options with regards to available donors? By the way, fantastic work with the DCD program and Hep C program. What do you think is the right ratio of patients in communities? So for every 1,000 heart failure reduced EF patients, how many patients do you think should be being considered? And where do we get that level of benchmarking data to help us? Because I don't see it available easily from across the country.
All right, thank you very much. That's an incredible question, and I think that it's something that most healthcare systems struggle with. If you go back to for example the Duke example, with the same catchment population as UNC, Duke is probably going to do 100 heart transplants this year, and UNC is at about 15 to 20. So I think that it has to do a lot with making sure that you're getting the word out in terms of at what point should we be sending the patients in. And I think this is kind of something that at least Dan, myself, working hard on to get those patients to us at the right time before they have end organ dysfunction that makes it very difficult for us to transplant them. The vast majority of patients that have come to us for evaluation in recent times have probably would be beneficial for them to come about a year sooner. So and our sensitivity, I think, is very, very high in terms of who gets converted over to needing advanced therapy. So I suspect that we probably should be getting 5 to 10 times more referrals overall a healthcare system of our size is in terms of like just the epidemiology of advanced heart failure, probably should be doing 50 to 70 heart transplants a year. That based on kind of equivalent systems, but that has to do a lot with how we are set up in terms of being what Harlan has been talking about for so long, which is a truly learning healthcare system where the different parts of the healthcare system recognize high-risk features and allow that patient to get funneled into the right direction. And I think that that's kind of something that we'll have to work on for the next few years, where we see these high-risk features, we get the patient in to see us, not necessarily to get them a transplant or VAD, but just to keep them kind of on our radar and get everything done so that when they get to us, it's not when they're crashing in the CCU with PA pressures that will result in a poor outcome after a heart transplant if you're able to do that. So the clear answer to you is I don't know what the right number should be, but I think that it's significant times higher than we're doing right now. In terms of LVADs, unfortunately, I think that with the new allocation system, I think that it becomes very difficult to make the case for doing an LVAD today in a large percentage of people with end-stage heart failure. The data shows more and more that we underuse donor organs considerably. So the gold standard in 2020 remains heart transplantation. If an LVAD comes along that doesn't have a driveline and has less risk factors than heart transplant, then that might be a game changer. But for now, I think that the number of LVADs is going to go quite down in most places, where the only people who qualify for LVAD would be who don't have a clear, who are not candidates for transplant anymore, which is getting smaller.
Well, thank you very much, Tariq. If there's no further questions, then we'll conclude today's Grand Rounds, and hope everyone will join us again next week for yet another remote cardiovascular medicine Grand Rounds. Thank you very much. Take care.
Thanks, everyone.